Hello, I'm Denise Willis, one of the section editors for Respiratory Care. This video abstract features an editor's choice publication from the September 2024 issue from Berg and colleagues regarding a respiratory therapist-driven mechanical ventilation protocol for lung protective ventilation. Lung protective ventilation has shown to reduce complications of mechanical ventilation, such as decreased incidence of lung injury and pneumonia, as well as decreased length of stay and mortality. This was a pre- and post-study of an RT-driven protocol for lung protective ventilation that aimed to evaluate the association between protocol implementation, adherence, and clinical outcomes. A protocol for initiating mechanical ventilation in the ICU was developed that empowered RTs to determine ventilator settings. The protocol incorporated 5 components designed to decrease the incidence of lung injury that included guidance for setting tidal volume based on ideal body weight. PEEP was set based on body mass index. FiO2 is titrated to maintain a target oxygen saturation, or PaO2. There was a settings range for breathing frequency and a 30-degree head of bed elevation. The study included adults admitted to the ICU who were receiving invasive mechanical ventilation for at least 24 hours. Patients who developed ARDS within the first 24 hours, required ECMO, or who were admitted for lung transplantation were excluded. Subjects were divided into pre- and post-intervention groups. The primary outcome was adherence to the protocol, and clinical outcomes were secondary that included development of ARDS 24 hours after admission, incidence of ventilator-associated pneumonia, the number of ventilator-free days, and death within 1 month of ICU discharge. Additionally, RTs were invited to complete a survey about the protocol 6 months after it was implemented. The study included over 600 subjects, with 456 in the pre-implementation group and 210 post-protocol. Overall, there was increased adherence to the lung protective ventilation components after the protocol was implemented. There was an increased odds of adherence to 3 of the components, which included PEEP, FiO2, and breathing frequency. There was a decreased odds of developing ARDS post-intervention, but there was no difference in other clinical outcomes such as the incidence of ventilator-associated pneumonia or mortality. 58 RTs completed the post-implementation survey, and the majority agreed that the protocol was effective in providing lung protective ventilation strategies. However, some felt that team communication had worsened with implementation of the protocol. Overall, the RT-driven protocol was found to increase adherence to lung protective strategies for mechanical ventilation, and fewer subjects developed ARDS after the protocol was implemented. The majority of RTs agreed that the protocol was safe and improved patient care, but it was unexpected that some felt communication had worsened because it was thought that the protocol would free up staff to discuss other aspects of care. The limitations of this study included that it occurred at a single center, which limits generalizability. The ventilator settings were only analyzed at 1 hour after intubation or ICU admission. Several different ventilator modes were used, and exhale tidal volumes were not collected. In conclusion, the RT-driven protocol increased adherence to lung protective ventilation strategies for mechanical ventilation, and use of the protocol was associated with a decreased incidence of ARDS. The authors proposed that future work should focus on identifying effective strategies for change to support and improve team dynamics. Thank you for taking the time to view this video. Check out our content on any of our social media platforms.